there are definitely different grading systems for different clinics. So let's understand that there's something called the Gardner criteria, which is like, it's a pretty standard way to do it, but it's not what everybody does. That's the one where they give you like the number and then the letter and the letter. So the number is the stage of blastocyst development. Blastocyst means it's the stage that the embryo should be at about 5 to 7 days of life. And then the letters, one of them describes the quality of the cells in the trophectoderm. The trophectoderm is what becomes the placenta. And then the other cells, the other letter talks about the cells in the inner cell mass. And the inner cell mass is what becomes the fetus. So just that's what they mean when they say like, 3AB or 4BC. It's the stage of blastocyst and then what the cells look like. Like that tells us about implantation potential. So the grading of the embryo talks about implantation potential. It doesn't tell you about a healthy baby. It doesn't tell you whether it's genetically normal. It only tells you about its potential to implant. So that's kind of the point of the embryo grading. What would cause a high quality embryo to not implant? Like, why doesn't it work? I think about it in 4 categories. 2 are related to the embryo and 2 are related kind of to the person, to the woman. So in regards to the embryo, 1, the embryo might not be genetically normal. So even though if it looks beautiful underneath a microscope, it's a 5AA, it could still have the wrong number of chromosomes and not give you a pregnancy. So that's number 1. 2, it could be genetically normal, but maybe there's something else going on with the embryo that makes it not implant. So think like, what if the woman was a smoker or the guy was a smoker, or the cycle was all overstimulated and the egg quality was bad, or the guy has DNA fragmentation, or who knows what else, like some other thing. I mean, this is the part that we really don't quite understand, like some other issue with that egg or sperm of that embryo that might not give it the potential to continue to grow. And then in regards to the patient, there could be something going on with her uterus. So there could be issues with receptivity. That's the whole, endometrial receptivity assay where they try to make sure that the amount of progesterone a woman has received is appropriate and, gives a proper receptive window and timing. They could have inflammatory factors people are looking into, like that are related to either endometriosis or endometritis. She could have a polyp or scarring or some issue going on with or maybe her endometrium looks good on one protocol, but not a different protocol, or it's not thick enough, or it's not trilate, whatever. There's all different things that can go on with the uterus. And then there's other things that could be going on with the woman herself that affects implantation. What if she, has an uncontrolled thyroid disease, or what if she, has elevated hemoglobin A1C, which is associated with diabetes. So I will say that, like, I think the hardest part, like hopefully the next thing we figure out in our field is why genetically normal embryos don't implant, because that's still, I think, one of the tougher parts of our field. We haven't quite figured out, for patients who sometimes have either are young and we think they have genetically normal embryos, or patients who we know or we think likely they're genetically normal because they've done testing and they've had 2, 3, 4 embryos transferred. Like, why aren't those people having ongoing pregnancies? I think that's a really tough part of our field we're still trying to figure out. And it's very much in the gray zone. There's a lot of, testing we do and, treatments we do that we're still trying to understand the effectiveness of those things. So